Welcome back. In today's video, we are going to discuss about the new initiatives in the family planning, including the social marketing, followed by the contraceptive efficacy, including the Pearl Index and life table analysis, and lastly, we'll be dealing about the unmet needs of the family planning. With this, we'll come to end of the demography and family planning in today's video. Let us start with the first thing, that is the new initiatives which have been included in family planning. We have three things, that is Antara, Chaya and Asha. Antara are the injectable hormonal contraceptives, that is depot medroxyprogesterone acetate, and we have Chaya, which is an oral contraceptive pill also known as Sant Croman or Saheli. Previously it was known by the brand name Saheli. Now it has been changed into Chaya. So we see that we have Antara. Antara is a hormonal contraceptives. Then we have Chaya. Chaya is a OCP. And then we have Asha. What is Asha? All the contraceptive methods under the government of India is given a brand name as Asha. Asha includes all the contraceptions, including the OCPs, IUDs, the hormonal contraceptives like Antara, Chaya. All of these are given in the brand name Asha. Now we have something called Mission Parivar Vikas. In those districts where the fertility rate was increasing, there were some 146 districts which were noted to have a higher total fertility rate. So these Mission Parivar Vikas was implemented, wherein they accelerated, they brought in the awareness about the use of these family planning methods in order to reduce the fertility and the population. We see that it is done to accelerate the use and awareness of family planning method in 146 high total fertility rate districts. Now, we have fixed day static approach, that is nothing but the sterilization services. So, we have terminal methods like vasectomy, tubectomy, which has been performed by conducting camps. So, we have camps which are conducted at the district hospitals at twice a week, in the sub-district hospital weekly, and CHC and PHC it is fortnightly and monthly. So, we see that both of district hospital and CHC, district hospital followed by CHC, it is fortnightly or twice a week. In PHC it is monthly, and it is sub district hospital it is weekly, or you can remember like this: district 2 times, sub district so 1 time. This is weekly. Now we have fortnightly in CHC, that is 2 weeks, once in 2 weeks. Again once in 2 weeks, that is fortnightly in CHC, and PHC it is monthly once. Okay, once monthly. Social marketing. Now what do we have under social marketing? You can see these condom vending machines. So this is an example. For now, let us start. What is social marketing? By the means of social marketing of these family planning methods, you are going to influence the social behavior, not just to benefit the marketers but also to benefit the target audience and the general society. Our main aim is not to benefit those marketers or the manufacturers of these condoms or many other things, but our main objective is to benefit those target population and the general society, the community people is what our target is. The example of social marketing could be the installation of this condom vending machines at the petrol pumps, parks, public toilets, bus or railway stations, in bars, restaurants, etc. So by this the easy availability of condoms will be made, and the easy availability will make the will increase the use in the community. Now we have the pregnancy testing kit called Nischay kit. Nischay kit is the pregnancy kit which is given by the government of India, and also this at sub centers or through the Asha, these pregnancy kits can be made available. You can get it through the Asha under the brand name Asha, by this at the sub centers, PHCs, and so on. We get this pregnancy testing kit called as Nischay. Now we also have a new initiative wherein the home delivery of the contraceptive is done by the ASHA workers. Now they have launched a new scheme so that this utilization of these services can be made, wherein the ASHA has to deliver the contraceptives at the doorsteps of these beneficiaries. We see that the home delivery at the doorsteps, these ASHAs will go and deliver the contraceptives. This scheme has been launched in 2011, and it has expanded to the entire country. Now we see that these home delivery, Asha now is charging a nominal amount for these beneficiaries for her effort to just come from the PHC, CHCs, and other centers, and then she's coming and delivering these contraceptives at the doorstep of these beneficiaries. So she charges rupees 1 for a packet of 3 condoms, and she charges rupees 1 for the complete strip of OCP, that is one cycle of OCP, which contains 21 OCPs plus 7 iron pills. So she charges rupees 1 for the entire sheet of OCPs, and rupees 2 for a pack of 1 tablet of emergency contraceptive pill. So this was about the home delivery of the contraceptives. Now we also have ensuring the spacing at birth. So another new scheme has been launched by the government of India. The services of Ashas to be utilized for counseling these newly married couples. What is the work of this Asha workers? They have to ensure the spacing at birth by counseling these newly married couples to space 2 years after marriage. So see, we also have first I will tell you generally what this ensuring spacing at birth means, and followed by how much incentives the ASHA workers will get. So the ASHA has to counsel the couple to ensure 2 years of gap before having the first baby. After the marriage, ensure 2 years of gap, and the couples with one child have to should have a space between 2 children, that is 3 years of gap has to be maintained between the first child and the second child, and this scheme is operational in around 18 states. And now let us see the incentives what the ASHA workers get. Also the introduction of the postpartum IUD. So we see that the Ministry of Health and Family Welfare has started to introduce the short term IUDs, that is Copper T 375, which is having 5 years efficacy. Under this national family planning program, this Copper T 375 has been introduced, which is having a short term contraceptive effect of 5 years, and this has been done at the subcenters level, wherein this IUCD insertion has been encouraged in the postpartum women, promoting this postpartum family planning services at the district hospitals by providing a placement of family planning counselors has been placed, and the training has been given to these personnel, and thereby they are going to encourage these postpartum women to get an IUD inserted. And the ASHA gets these incentives under the scheme: rupees 500 to the ASHA for delaying the first childbirth by 2 years after marriage. First she have to counsel them to have a gap of 2 years after the marriage, before the first baby is born. Soon after the marriage she has to have a gap of 2 years before her first baby. If she is successful in counseling the couple, and the couple has their first baby after 2 years of marriage, it means that the ASHA gains 500 rupees. And if the ASHA gets another 500 if she is ensuring a spacing of 3 years after the birth of the first child. And also she gets rupees 1000 in cases of the couples who opt for a permanent limiting method up to 2 children only. If they undergo the terminal method, that is tubectomy or vasectomy, after the two childs and then 2 children, if they opt for the terminal method, then the asha gets 1000 rupees. So these are the incentives which the asha workers get, by implementing this new promotional schemes and creating an enabling environment. And these antara programs, oral contraceptive pill programs, chaya, these existing contraceptives is providing the new users the new options, because they are provided with the government of India. They are quite easily accessible to the users, and thereby increased reduction in the fertility rate can be brought in. Now, let us move on to the contraceptive efficacy. Contraceptive efficacy can also be studied with the help of Pearl Index or the life table analysis. Let us start with the contraceptive efficacy, wherein the assessment of number of unplanned pregnancies that occur during the safe period of exposure or use of contraceptive method. So, it is nothing but, in simple language, the failure of contraception or the accidental pregnancies which are occurring in the women. So we see that there is an unplanned pregnancy. This unplanned pregnancy is occurring during her safe period. It was not supposed to occur during the safe period, but now an unplanned pregnancy has occurred during the safe period, or in spite of the use of these contraceptive method, she is landing up in an unplanned pregnancy. So how do we assess each of the contraceptive method and what is their contraceptive efficacy? We have two methods. In the first, we have Pearl Index and life table analysis. The Pearl Index have certain formulas. We have number of contraceptive. By the Pearl Index, we calculate the number of contraceptive failures or the accidental pregnancies per 100 women years of exposure. So now we know what is per 100 women years. Per 100 women years is nothing but this a woman or a couple who has been using one contraceptive for a period of 1 year. 100 women. So we see that here we are considering why 100 women years. What do you mean by 100 women years? 100 women or a couple who have been practicing one method of contraception. It could be IUD, it could be OCPs, it could be any other barrier methods like condoms for a period of 1 year. Then that is 100 women year. Now we see that the Pearl Index, with the help of Pearl Index, we see that the total accidental pregnancies, what are we calculating? The total accidental pregnancies which are occurring divided by the total years of exposure to that contraceptive into 100. It's one of the formula. We can also calculate it by the total accidental pregnancies which are occurring by the total months of exposure. 1 year has 12 months, right? So 1200 into 12, we are taking 1200 here. Total accidental pregnancies by total months of exposure into 1200. Now, total accidental pregnancies by total number of menstrual cycles experienced. So, we know that 1 year contains 12 months. The shortest cycle could be of 26 days. So, a woman almost goes through 13 cycles in a year. So, we multiply 100 into 13 and thereby we get number of menstrual cycle experienced into 1300. So this is how we are going to calculate the Pearl Index. What does the Pearl Index indicate? It gives us a value of the number of accidental pregnancies which are occurring in 100 women years of exposure, and the number of contraceptive failure. Contraceptive failure is nothing but the unplanned pregnancy or the accidental pregnancy. Now we have calculated the Pearl Index. In cases of male condoms, it is 2 to 14%. So 2 to 14% accidental pregnancies can occur per 100 women years of exposure. That is, for a period of 1 year, if 100 women are using, in them 2 to 14% failure rate is seen. In cases of IUDs, it is 0.5 to 2%. In cases of oral pills, it is 1.5 to 0.1 to 0.5. So clear guys, in male condoms it is highest 2 to 14%. In cases of IUD, 0.5 to 2. And in cases of OCPs, it is 0.1 to 0.5. Okay. Now, life table analysis. Now we are moving on to the other thing, that is life table analysis. The females of reproductive age group who are observed to analyze any accidental pregnancies. Even in life table analysis, we are observing and analyzing the accidental pregnancies which are occurring in the women of reproductive age group. They also calculate the failure rates which are occurring per month of use. So they are going to calculate the failure rates per month of the use. Just like in Pearl Index, we calculated total months of exposure. Similarly, in life table analysis, we calculate the failure rates which are occurring per month of use. It is quite better than the Pearl Index. Now we are going to the last topic of demography and family planning, that is unmet needs of the family planning. So what do you mean by this unmet needs? Unmet needs is nothing but the percentage of women of reproductive age, either they are married or in a union, who have an unmet need of family planning. So it means that women who are sexually active, it means that the women of reproductive age group who are sexually active, they could be married, or they could be in a relationship, union, which means relationship, who have unmet need of family planning. It means that, but they are not using any contraception and would prefer to avoid becoming pregnant. They prefer to avoid pregnancy, but they are not using any sort of contraception. And this is the unmet need is higher in rural areas. In urban areas, people are educated, there is much exposure and awareness, but these unmet needs, who are in a union or who are married, they don't want the kid, yet they are not following any sort of contraception, including the use by their partner. Even the male doesn't use any sort of contraception. Then these women are considered to have an unmet need. Their need is to avoid the pregnancy, but they are not using any sort of contraception. So what did it become? It became an unmet need for family planning. However, this method is also applied to those who are sexually active, fecund women, and perhaps to men also who have been limited their marriage to women only. And now we see that this unmet need now has been gaining a powerful concept for the family planning, because it is posing a challenge to the family planning programs to reach the millions of women who have a reproductive attitude resembling those of contraceptive users, but they are not using any contraception, yet they are having a behavior or a pattern wherein it shows that they are using some sort of contraception. The main reason for this is the lack of information and also fear about the contraceptive side effects. Mostly in urban areas, they fear the side effects of contraception. Nobody wants to risk their fertility. The spacing is much required, but not at the cost of losing their fertility. So people have this myths and lack of awareness, wherein they believe that fertility cannot be regained with the use of these contraceptive methods. And also they could have an opposition by their husbands, and all such reasons could be there because for the unmet needs. It includes the women who wants the family planning in order to delay their childbearing, but they are not using any method of contraception. Unmet needs of family planning in India, we see that women less than 20 years, spacing the birth is their main object. Spacing methods of contraception What are the spacing methods? We have barrier methods, we have barriers, condoms, diaphragms, and everything. We have discussed in detail all the methods in the previous videos, which are available in the playlist. So we have barrier methods, OCPs, hormonal contraceptives, then this IUDs, intrauterine devices, COPTs, multi-load devices, all of these in cases of spacing the children, spacing the birth in cases of women less than 20 years. The women who are aged between 20 to 30 years, okay, who are aged between 20 to 30 years, they would also prefer spacing the birth. Spacing methods of contraception, just like in we saw barrier method, hormonal contraceptives, and then intrauterine devices, all of these are preferred. Now, for the women who are aged more than 30 years, they would have completed their family size and they would prefer going for limiting the birth. That is, they will opt more for terminal methods, that is tubectomy, vasectomy, where the terminal methods of contraception would be preferable. The total unmet need in India is 12.9%, out of which the total unmet need for spacing birth is just 5.7. So we see that out of this unmet needs completely, we have 12.9, around 13%, out of which 6%, rounding off, is the half of which is less than half is the like the spacing of birth. The rest require the terminal method. Okay, I hope it's clear. The total unmet is 12.9, out of which spacing birth is 5.7%. I hope everything is clear. With this, we come to an end of our chapter demography and family planning, wherein we discussed many topics. And then if you have any doubts, put it in the comment section, and have any requests for starting any chapter, you can ask me down in the comment section, and I would like to do that chapter first. Thank you, and if you like my video, hit the like button and subscribe.